Assalamu alaikum. Good evening, everyone. Welcome to Patient Safety and Emergency webinar. This is Rawan Sultan. I am the Head of Learning and Reporting section at the Saudi Patient Safety Center, and I will be serving as your moderator today. You will be hearing a presentation from Dr. Mohammed Shiha, who will be talking to us about safety and emergency department. Dr. Mohammed, our speaker, is an emergency medicine consultant. He's currently serving as ED chairman and emergency medicine clinical service lead in Riyadh First Health Cluster with a fellowship in medical toxicology. Before we start our presentation, I would like to remind you all that the abstract submission for the third SPSC Patient Safety is currently open. Also, the fifth National Patient Safety Award with different tracks is currently open. The deadline will be September 30. Please, for any question, write them down in the Q&A section. Dr. Mohammed gladly will answer them at the end of our session. حياك الله Dr. Mohammed, the mic is yours.
Thank you, Rawan. Thank you to you and to the Saudi Patient Safety Center for allowing me and giving me a chance to speak about this important topic, the patient safety, and particularly in emergency department. So before we start, we need just to have a look at the definition of patient safety. So patient safety has many definitions. The most famous ones are by the WHO, where they define patient safety as a healthcare discipline that emerged with the evolving complexity in healthcare systems and the resulting rise of patient harm in the healthcare facilities. It aims to prevent and reduce risks, errors, and harm that occur to patients during provision of healthcare. The NHS have a similar version, which is the avoidance of unintended or unexpected harm to people during the provision of healthcare. The concept of patient safety actually is an ancient. It started all the way since the Hippocrates days. If you remember, during our medical school, if you took the Hippocratic oath, a crucial line in that oath is, I will abstain from all intentional wrongdoing and harm, etc. This was written 275 AD. And nowadays, we have healthcare facilities, we have hospitals. It's not upon the healthcare provider, which was the doctor at that time. Hospitals' safety usually has three components: the safety of the place, safety of people, and safety of the property. Let's look at each one of those in a short glimpse. Then we will talk about them in depth. When we talk about the place, we want to make sure that our infrastructures are safe. The building, the electricity there, the mechanical methods that we're using over there, and we're safe from fire. Security is an important aspect of infrastructure safety, and it's related to it. And we're talking here about, when we talk about security, we talk about the patient security, we talk about the healthcare provider security, and everyone inside the facility. And the infrastructure plays an important role in that. Next one, the safety of property. And the property here is the facility itself. It's not the physical facility only, but the equipments that we are using inside that facility, the X-ray machines, the labs, everything that we use to help us to provide best healthcare. The stores where we store our papers, where we store our equipment, where we store our medical devices, and the assets. And the assets here is not the physical assets, as we mentioned earlier. The assets here is the knowledge, the confidential files, the policies, and any other thing that we consider it as assets in our property. People, this is the first thing that we think about when we think about safety. Staff, visitors, and patient all have the right to be safe in healthcare facilities. And if you know that the safe environment for the staff is the main engine that will push the vehicle of visitors and patient safety forwards. So patient safety has received an increased attention since the late 1990s. And to document patient safety issues and to improve the care and reduce the error, the Institute of Medicine published a couple of reports. For example, in 1999, they established their first report, To Error is Human, Building a Safe Health System. Then it followed in 2001 by another detailed report, which is Crossing the Quality Chasm, a New Health System for the 21st century. However, those reports were underestimating the extent of medical errors and preventable harm. They were more general. They were speaking about everything, about the property, a facility, and they didn't pay much attention to the medical errors. This is the domains that Institute of Medicine that consider a high quality care. They want it to be safe and effective, and patient-centered, and etc. And as I mentioned earlier, this wasn't medical-oriented or medical care focused. So what happened? After this report appeared, many specialties began to seriously evaluate their own safety issues. And among those specialties, emergency medicine, of course. And they started to identify several problems and areas to improve and attempt to determine the epidemiology of errors. One study of 62 urban emergency departments found that at least 7% of patients who presented for MIs, asthmas, or joint dislocation that required procedural sedation experienced an actual or near adverse event, 7%. Another study showed that up to 12% of all return visits to ED within 7 days were related to adverse events. If you are an emergency care worker or who visited to work at emergency, you will notice that the ED settings itself undoubtedly is a risky place. But why is that? The ED is unlike any other area in the hospital or other healthcare settings. It has, like patients, they seek care for both primary care and urgent care compliance at any time of the day, during all the 24/7, any day of the week, and when other sources are not available. Also, the ED settings is a fast-paced and require quick thinking, broad depth of knowledge about many medical conditions, and a broad range of skills to perform emergent and life-saving procedures. Often, patients are presenting to a hospital ED for the first time with incomplete medical records. They may not know their medical conditions or medications, or be in a position that we cannot communicate with. Another thing, the emergency physicians are required to care for multiple patients of different ages at the same time. And they need to prioritize the care of critically ill patients who have MIs, strokes, etc., sepsis, versus the colder patients. For many ED patients, diagnosis and treatment can be complex. As you see from this graph, how the emergency system is complicated, is related, there is a relation between the bystanders and the ambulance, the clinics, the hospital, and even the community. In addition to that, ED overcrowding, which is a problem that I'm sure that anyone who was in emergency faced it somewhere due to limited availability of beds or patient flow to the inside the hospital. It may consume resources and staffing needed to care of active patients and new patient who comes to our emergency. Any of those situations alone can lead to a catastrophic events. In combination, they can significantly increase the risk of harm. Safety factors in ED can be categorized as those related to patients, provider, and environment. If you look at this table, the patient-related issues lies on the left side, while we have the provider and the environment system related. If you have a look at this table, as I mentioned, you will see that most of those conditions are everyday business in emergency. For example, if you look at the patient-related factors, the age extremes, the mental status changes, the cognitive impairment, the lack of knowledge of medical problems, complex medical conditions, all are things can increase the risk of patient harm. When you come to provider-related factors, the experience, fatigue, shift works, missed tests, the procedural errors, the transaction of care, which is the endorsement from one shift to another, can do the same. The environment and system related, like overcrowding, boarding, lack of complete medical records, and difficulty of using electronic health systems can lead to patient harm. And if you sit back and you start to think which one of those factors can lead to most of patients' harm, you will find it's the system-related issue. So when a large academic urban ED study studied itself, 2/3 were attributed to system issues. So with all those signs of uncertainty, all those risky information that I provided earlier, as a healthcare provider, how did we handle those situations in our emergency department? And the question is, we created a culture of safety. So developing and maintaining a culture of safety is a commitment to minimize adverse events when performing high-risk jobs that can result in harm. This concept of minimizing risk with a high-risk job originated in other industries, actually, before emergency, such as airlines and nuclear energy industries. All those high-risk jobs or high-risk environments, they created a culture of safety, and emergency medicine followed their steps. Organizations and companies are considered high reliability organizations when they are dedicated to prevent harm at all staff levels, from frontline to corporate level. And these HROs, or high reliability organization, promotes the reporting of errors and near misses without fear of blame or loss of employment. So what we can see here that if we want to be a high reliability organization, we need to promote the reporting and kill the blame culture in our emergency departments. In ED, a culture of safety encourages teamwork, event reporting, communication, openness, transparency with feedback and learning from errors, and collaboration from administration for safety. all those factors can create the culture of safety in our ED. With a strong safety culture, near misses are more likely to be intercepted to reduce patient harm. Teamwork training improves communication and reduces error, according to the studies. So let's talk about teamwork. If you heard about the program Team Steps, it's one such program. Team Steps, which is a team strategic and tool enhanced performance and patient safety, was developed by a joint effort of U.S. Department of Defense and Agency of Healthcare Research and Quality to promote interprofessional communication between all providers in hospital. This program provides many tools, include one to obtain attention in difficult situations, and one to escalate concerns to focus on important safety issues. One ED experience with the Team Steps led to identify specific steps to ensure continued success after initial start. To maintain the high level of teamwork and successful communication, this ED recognized a need of continued champions at all staff levels, and all new staff members were required to go through training. The other factor that can help to create the culture of safety is to promote reporting. It's an important aspect of a strong safety culture is to create an environment that promotes reporting of adverse events and near misses. The culture should allow a person to involved in an adverse event to feel comfortable reporting such an event. Otherwise, they will stop from doing that because they are afraid of getting blamed. In one study of 522 unintended events at 10 EDs in Netherlands, nurses reported up to 85% of the events. The resident physicians reported 13% of events. And around 83% of these reports were filed by a person involved in the event. And this is absolutely great. If you have like over 80% of your department are not afraid to report their mistakes, it means that you created a safety culture, you created an environment that promotes reporting without fear of blame. And this study highlights EDs that foster a no-blame environment where staff feel comfortable admitting mistakes, and there is no fear of punishment or concern for their job loss, can report more than usual other departments. When administration supports such reporting, the true safety problem in ED are identified and can be targeted for improvement. Patient safety has many aspects. It can, as I mentioned earlier, it can go through the equipment that relates to patient, the environment, the sanitation and infection control, fire electricity, all of those safety factors that I'm sure that you came across in your practice. Talking about emergency, there are many aspects that can happen and errors that can happen in emergency, but we choose to pick a couple of them, the ones that we think that they represent emergency uniqueness more than any other area in the hospital. And we left the general concerns that you can see in any part of the hospital. For example, fire safety and electricity hazards. You can find it in any area in the hospital. But the problems that we will mention here, they are more emergency oriented, and they are more like a day-to-day business to us as an emergency care provider. I will have a couple of case scenarios. And if you see this logo or the sign, it means it is a poll and your participation is highly appreciated, just to figure out where are we standing in this kind of culture. So the first case scenario, a 65 years old woman presented to the ED with atrial fibrillation with a rapid ventricular rate of 165 beats per minute. Her heart rate was controlled with intravenous diltiaz, and a heparin infusion was ordered based on her estimated weight of 150 pounds. As the pharmacist prepared the infusion, she rechecked the patient's weight and discovered that the heparin order had been placed using pounds instead of kilograms. The pharmacist discussed the order with the physician, and the order was changed to avoid double dosing error. So, from that case, where is the problem? Is it the health information technology, discharge process, medication safety, or transaction of care? As you see, you guessed it right. It's medication-related issue, medication safety. In AD, there is a wide range of medication we use in our AD. And it can lead to prescriber confusion. Different ages, extreme ages, young, old, mid-age, the gender differentiation, the body weight, same drug with multiple routes can go, like in this case, IV or IM or oral. In situation where a critically ill patient is close to death, like when we do in the CPR, we start to through verbal orders here and there. And then we follow the computer order when physicians are able to read the bedside. This can increase the risk of errors. Clinicians may be treating multiple patients with a similar condition or with similar names. And high alert medication are often used. And there have been studies showed that physicians, they were treating patients with same names, and coincidentally, they were receiving the same medications. And this happened in the West, where this is not common. Imagine us in our Arabian region, when we have a tribal name, like two people have like the first name and the similar tribal name. And this is a common thing to happen. If you consider all those factors, it's not surprising that up to 60% of ED patients experience medication error in one study. Fortunately, most of those errors do not result in immediate patient harm, but have the potential to lead to harm. In another study, which critique the first one. So, pharmacists. We mentioned pharmacists in this. The addition of a pharmacist to the ED 24 hours a day, 7 days a week, can greatly improve medication safety. Emergency department pharmacists are available for immediate bedside consultation or discussion of medications order, and can intercept prescribed error before they administrate it, or it results in patient harm. They can recommend appropriate antibiotic dosing, as one study showed. They can give aid to administration of medication for such emergent condition and procedures, especially when it comes to critical conditions like stroke, or MI, or trauma, or RSI. In general, and pay attention to that, medication errors are 13.5 times less likely to occur when a pharmacist is on duty in the ED. This is a lot. And this is like show how important having a pharmacist in your ED. Some other thing the pharmacist can do. The pharmacist also can they ensure to look to make sure that we don't fall in LASA, which is look alike, sounds alike medications. When two medications they look the same, they sound the same, but they are not the same, and they make sure that we're not confused about it. Importantly, in overcrowded ED, the pharmacist reviews medication order for all inpatient boarding patient in ED. It's a critical thing. They can ensure that the nurses obtain the appropriate medication from automated dispensing cabinet. In some instances, neither the emergency physician or the nurse are familiar with the proper dosing and scheduling for scheduling of medications typically used only in patients. Especially, we keep a lot of boarding patients in our emergency, and when we come to give them the inpatient medications, you will realize that not even a consultant or a senior nurse have an idea about what is that. Pharmacists can prevent errors from formulation confusion, LASA, as I mentioned, weight-based doses, as our case, and dosing frequency error, which can be further complicated by sheer volume of patient in ED. They also can ensure that most of up-to-date evidence is used to support a medication's order, and they can also ensure best practices and adhere to hospital policies. This is like another table about the best medication safety practice in emergency department. It summarizes what I mentioned earlier from using a couple of policies. But if we use those recommendations, we will be able to reduce patient harm. Like for example, pharmacists available in ED 24/7 for consultation and cognition. Use computer order entry instead of writing orders. Use of decision support from best practices. Weight always in kilograms. Use automated dispensing cabinets. Nurses administer medications rather than physician or paramedics. Use of a barcode medication administration. Use of intelligent infusion pumps to for the IV infusions. And except avoid the confusion appropriation. Second case, a 55 years old man on warfarin presented to the ED with a cough-based EMP. His chest X-ray relieved a right lower lobe pneumonia. He was prescribed levofloxacin and discharged home. His discharge instructions included a discussion of pneumonia, his fever, and the importance to take his antipyretic appropriately. But he was not told to have his INR checked regularly while taking levofloxacin. Patient returned to ED after 5 days with a rectal bleed, and when they checked his INR, it was elevated up to 6, given the fact that the targeted range for this patient was between 2 and 3. So what do you think happened? Health information technology, discharge process, medication safety, or transaction? So exactly, as you guessed. It's a discharge process call. So when patients who do not require admission to the hospital discharge home, they need instructions to ensure that they fully understand the nature of their problem and what they need to do to get better. For the provider, the discharge process must include 3 tasks: communicate with crucial information like a diagnosis or written instruction, verify the patient comprehension of the information presented, and address and correct a specific concern and misunderstanding. The encounter must be standardized, but also be flexible enough to ensure patient understanding across a wide range of healthcare literacy and cultural background. Patients frequently are not given appropriate verbal and written instruction, unfortunately. And if they don't understand their diagnosis, they may not follow up when necessary, may not realize they need to take specific medication, or might not take their neuroprescribed medication as intended or at all. In an evaluation of a written discharge instructions, only 76 include the diagnosis or an explanation of the patient's symptoms, and only 34% provided instruction on when, how to return. One study described that. Another study of the discharge process showed that the average verbal discharge exchange lasts only 76 seconds. This is the average, less than 1.5 minutes. And that 65% of instructions were not complete, more than 2/3. Patients were often not given a diagnosis, an explanation on their prescription, or proper written prescription. So as you see here from those studies, the deficit in the discharge process places the patient at high risk of not using their medication in a good way, and has a high risk of returning to emergency. The discharge exchange must provide information on diagnosis, what was done in ED, and what needs to happen next. This must be done both verbally and in written, patient's native language. As we see, like we have in Saudi Arabia, we have a lot of people who doesn't speak Arabic, and at his or her health literacy level. So if you have someone who's he knows or she knows about healthcare, he has like some healthcare knowledge, we should go with the literacy level versus someone who doesn't know anything. There should be time for patients and those accompanying them, and who are also responsible for their health, and also the ones who are responsible for their health, to ask questions to ensure that everyone understands what has taken place and what must be done after leaving the ED. Patients should be given information on all over-the-counter medications, and they should be instructed if they should or should not take it, if they should change their previously prescribed medications, and etc. The case scenario number 3, a 70-year-old man with hypertension and hyperlipidemia had an episode of chest pain and was evaluated in the ED for possible MI. His initial ECG was showing non-ischemic changes, and his troponin level was below detection level 30 minutes after this episode. The initial provider was leading the ED, and he endorsed the patient to the oncoming emergency physician with the instruction to follow the chest X-ray interpretation. The initial provider, however, did not tell them the oncoming emergency physician to check the result of the troponin, the repeated troponin, and the patient was discharged home after the second troponin test has been sent to the lab, but before the result had been checked. Where is the problem source in this case? Healthcare information technology, discharge process, medication safety, or transaction of care. Again, you guessed it right. It's a hands-off and transaction of care problem. Emergency department patients still under who are still under evaluation or in a process of being admitted to the inpatient hospital are handed off to the next shift of providers, like every time we do in our shift. Hands-off or transaction of care place patient at an extremely high risk of adverse event or bad outcomes. Important information can be lost whenever care is transferred from one person to another. And for example, there can be a lack of communication about pending tests, like what happened in this case that needs or require follow-up, the need for further testing or continuity of the planning for any problem that may arise. Loss of information and lack of follow-ups can lead to diagnostic error and improper disposition. During the pre-turnover, the initial provider should review what has happened and to prepare the patient for the next shift. According to the Joint Commission of the 2006 National Patient Safety Goal, hands-off should be standardized. Therefore, they recommended 4 stages for safe ED provider to ED provider hands-off, which is like the pre-turnover, arrival of the new provider, meeting of providers, and post-turnover. If we take it step by step, as we mentioned, the pre-turnover, the initial provider should review what has happened in the patient care and what is the next step needed to finalize for patient disposition. The arrival of the new providers, this is the second phase, signals the start of new shifts as we know. During the meeting between the new provider and the post provider, important information should be verbally transmitted to the oncoming provider. This meeting needs to be standardized to include a patient summary, tasks, and tests to follow up. And what is the plan? Many tools can aid in transaction of care, include verbal, mnemonics, tools to integrate with the medical records, and to develop the complete process for transaction of care. After that, the post-turnover is completed by oncoming providers as he or she finishes any tasks related to the patient's care to ensure that the treatment plan is completed. There are many ways to improve the safety of hands-off. First, the number of hands-off should be limited. Having more patient dispensed by the provider who initiated their care, reduce the risk of an adverse event. This can be accomplished by having overlapping shifts to allow outgoing providers time to complete care for their patients. During the hands-off, interruptions and distractions should be limited to give the off-going provider appropriate time to present a clear information, a complete overview of the patient care, and communicate all outstanding tasks as to do or action list. There should be a time for oncoming provider to ask questions to ensure he or she is clear about the next step. At the end of transaction, there should be some signal that the patient care is passed on to the incoming provider, and the outgoing physician should leave the patient care area to finish documentation. Many ED patients will need transaction from ED patient to admitted patient, and this process should be done also when we pass those patients to our colleague inside the hospital. Studies on transaction of care from the ED to an inpatient medical service have found multiple barriers to a seamless transaction of care. This includes communication failures, information technology failures, inability of patient providing to review vital signs, lab values, and medication given, a change of inpatient team to whom the patient was assigned, and patient transferred to areas removed from ED with in an inpatient floor, such as to dialysis unit. In one survey, 29% of respondents report that patient of theirs had experienced an adverse event or a near misses due to poor hands-off between ED and medical service. Just as there needs to be standardized process for ED provider to ED provider hands-off, there's also should be a standardized process between ED to inpatient or ED to outpatient services. There should be verbal and possibly written transmission of vital information with patient summaries that shows what to do, what are the follow-ups, and the situational knowledge, and continuity of planning and time for question. The Joint Commission Transition of Care portal offers a tool to help to facilitate formalize this process. This is a suggested tool to help to facilitate and formalize the process. Should have like a standardized verbal and written hands-off, limit the number of patients hands-off, and hands-off should be including the patient summary, to-do list, and the time for new provider to ask question, and closed loop communication between providers. And this should be standardized between ED to ED and ED to or inpatient providers. Last case for the night. An emergency intern was instructed to order a dose of IV morphine for a patient with fractured hip. The intern used an electronic ordering system. Afterward, the nurse caring for the patient asked the attending physician if she really wanted to order patient-controlled morphine analgesia for the patient. Upon reviewing the order, the attending physician discovered that the intern selected the first morphine on the drop-down list, which was oral morphine, instead of scrolling down to find the range of individual doses available. Where is the problem here? You're right. It's a problem related to health information technology. The use of electronic health records and health information technology systems has both improved the patient care and introduced new errors at the same time. Physician handwriting may not longer be the problem as older days, but some hospitals use several types of EHRs. Simultaneously with the different system of inpatient, outpatient, and EDs. This may not allow for review of the different records or orders when they have different system between inpatient and ER, etc. There's an additional concerns, including communication failure, misidentification of patient's order, poor data display, and alert fatigue. And we'll talk about those things the next slide. Communication failure include the lack of bedside or face-to-face discussion among care providers. Physician may enter an order at the computer away from nursing station and never directly inform the nurse about the plan for the patient. Incorrect patient orders are usually self-explanatory. Some other errors, like choosing the wrong LASA medication that we mentioned earlier from the drop-down list, or ordering a wrong dose, wrong route, or the imaging field, we can order a study for the wrong side of the patient body. Poor data display may not alert providers if we have data that displayed poorly. For example, for patient with the same last name, not displaying the vital signs in a meaningful way. This display problem can lead to inability to distinguish abnormal results from normal ones if they're not using different color for the abnormal result. Conversely, the alert fatigue, which we mentioned earlier, which can occur when too many warning messages appear while providers are trying to enter order for one patient. These warnings can range from important messages, such as allergy identification or severe drug interactions, or non-critical alerts about the cost of the test, for example. And this might lead to alert fatigue, which can lead to a healthcare provider ignoring them, and by like the current ignoring and building this habit, we might miss an important warning message. Some recommendation to improve patient safety with the use of electronic health records or health information technology systems is to have a frontline staff champion, like what we did with the safety issue, to identify areas for performance improvement, review the process to identify and examine safety issues, to identify and examine safety issues with this technology. And it's important to have a group, a multidisciplinary group, include the frontline, which has to include the frontline staff, either a nurse or a physician, can usually develop effective solution to these safety issues. So from those 4 issues and the information that we mentioned, the home take message, we need to understand that our emergency department is a high-risk settings for slips. And because of its unique features of high acuity patients of widely different ages, and frequent need of use of high alert medication, and the need to take care of multiple patients at the same time, many interruptions by patients or staff or relatives, and a lot of distraction, the lack of a relationship with the patients, all those factors with the emergency environment to make the emergency environment as a communication failure environment. In hands-off and transaction care, medication error, and poor follow-up due to poor discharge process, those are all common areas of errors in emergency. Some additional difficulties can arise when we are using HIT systems or electronic health records, and are not set up for to ensure the success of frontline staff caring for ill patients. The ED can become a much safer place by establishing strategies such as those outlined earlier to reduce the error in all of these areas. Thank you for listening. This is my contacts if you have any extra questions. And if you have extra questions right now, I'm happy to answer. Thank you, everyone.
Thank you, Dr. Mohammed, for addressing this interesting topic. Safety and emergency will always be a top priority for all healthcare providers and leaders. Dear participants, if you have any further questions for Dr. Mohammed, please type it in Q&A section. I have chosen a couple of questions for you, Dr. Mohammed. The first one will be, as you know, that emergency departments have different policies regarding consultation, either one-way referral or refer back to ER. Which approach is safer for patients in terms of transition of care?
So, like, I don't like to answer it this way, but it depends. Policies in general are set to make patients safe and make sure that the workflow is smooth. I'll give you an example. If you're working in a medical city with where you have a huge amount of patients, big load, patients are coming from door every 10 minutes, multiple level of patient acuity, then the most appropriate approach here will be the one-way referral. But if you're working in a small community hospital where the whole emergency sees 10 patients per day, a hospital doesn't have a senior emergency doctors, consultant level, or experienced consultants, then the back to ER policy can be activated. As long as the patient is receiving the care inside the facility, both policies are valid. Just keep in your mind, we shouldn't keep the patient in the emergency department, as it will lead to emergency overcrowding, and this may affect the emergency patient's safety and care. As long as you don't have crowding, each policy can do so. Nice.
Thank you, Doctor. The second question will be, as there is a change in vision of emergency department to target 4 hours ED stay, are there any concern for patient safety within this limited window?
Sorry, I couldn't catch the first part of the question.
As we know that there is a change in vision regarding the patient stay in emergency toward 4 hours ED stay, is there any concern for patient safety?
Okay, so when we talk here about patient safety, we shouldn't mix them with the final diagnosis. To be honest, like moving patients from emergency within 4 hours is one of the goals of the Saudi Vision 2030. And it's a crucial part of the health system transformation, is not to keep emergency patients more than 4 hours. Someone would ask, how would I dispose those patients within 4 hours while I didn't reach a diagnosis? And my answer would be, you don't need to reach a diagnosis in emergency. What you need to do to start the initial management, to make sure the patient is safe, and to move the patient to the next health provider or discharge within the time window safely. And this is what we mentioned earlier, that we need to standardize the transaction process, not only between ED physicians or nurses, but between ED staff and the hospital staff.
Thank you, Doctor. We have another question for you. A lot of hospitals have a deficient discharge process in ED, and it's considered a risk for patient safety. From your perspective, how to mitigate this risk?
So, as we mentioned, the discharge process should have a standardized approach. We should conduct this process verbally and written. We should pass the information to the patient, how to use their medication, what are the risk factors, when to return to emergency. And we should pay more time and spend more time to explain to the patient, to explain the instruction to the patient based on their literacy level. Some hospitals here in Saudi Arabia and in Gulf countries, they use an electronic discharge system where you as a physician or a nurse, you put the information there, then the IA will print a paper with instruction on it. Then a further instructions can be printed on the prescription paper, and they attach it to the medications. But like all those things wouldn't work perfectly unless we as a healthcare provider pay more time and spend more time with our patients to explain for them. As you see earlier, one study showed that the average number of seconds that an ED provider spend with the patient to explain for them the discharge instruction was 76 seconds. 76 seconds, it's an extremely low time for someone who has some difficulties in communication or a different language than we using.
Thank you, Dr. Mohammed. And on behalf of the Saudi Patient Safety Center, I would like to thank you and to thank the audience for their active participation. And dear all, as a part of our center effort to provide you timely topics and interesting speakers, we would appreciate if you would fill out the evaluation survey, which will be sent to your emails after the session. Thank you for joining us today, and we look forward to welcome you back in future webinars. Thank you all.